diffusion. Okay, so always, these are the pages that you want to reference in your book. If you are struggling with this material or just want to have a little bit more information, this is where you want to go. Okay. So, did I skip a slide or is this the first, your guys' first one? Okay. I skipped one or this is the first one?
I skipped one.
Okay, thank you. All right, so again, ventilation is the V in our VQ ratio. So we're talking about normal VQ ratio. Q stands for diffusion, okay? So normally in the lung should receive the same amount of ventilation and pulmonary capillary blood flow. So that blank is same. And our normal VQ ratio, remember, is 0.8. And how did I get that? So I take my alveolar minute ventilation, and that's the average, and I divide it by my cardiac output, which remember 5 liters is about average, and that gives me my 0.8. So if I were to give you a cardiac output of 4, you would just pop that in there instead of the 5, and again, do the math. And if it's less than 1, it's gonna be shunt. If it's greater than 1, it's gonna be dead space. Okay, does that make sense? Okay. So that is the equation that we would use. It's really just dividing, okay? Okay, so that's our normal. Now if we have an increased VQ ratio, so when I say an increased VQ ratio, we have an increase in ventilation because it's greater than 1, right? So when I say increased VQ ratio, what I really mean is greater than 1, okay? So first blank, it can develop from either an increased in ventilation. So we have an increase in ventilation or a decrease in perfusion. This blank number 2. So remember, we talked about this. Pulmonary emboli, decreased cardiac output could be another one. If you have an extrinsic pressure on the pulmonary vessels, so that would be like a pneumothorax. There would be a whole lot of other stuff going on too, but it wouldn't just be a dead space thing. But this is considered to be dead space, right? If it's greater than 1, we're talking about dead space, okay? So if you see here, we have, it says a decrease, this is our blood flow, decrease O2 diffusion rate, reduces amount of CO2 returning to the alveoli. This up here has increased ventilation is what's happening here, what the cause is. So we are having a increase in ventilation, and that is going to change that ratio, right? If our ventilation is higher than that average of 4, that's also going to change my ratio and make it more of a dead space issue. Does that make sense how that's happening? Okay, so if I were to give you a different respiratory or ventilation, minute ventilation, sorry, and it was higher than 4, and you had the same amount of cardiac output, you're then going to have a greater than that 0.8, so it's going to be greater than 1 in that dead space. Does that make sense how I'm wording that, I guess? Yay or nay? Okay. So this is just telling you an increased VQ ratio. And whenever you think of, whenever I say increased or decreased VQ ratio, I'm always, a good way to like memorize this. If I'm talking about VQ, and if I say it's increased, or with an arrow up, it's always associated with the ventilation. So if I say increased VQ ratio, you can just in your head to remember it, increased ventilation. If I say decreased VQ ratio, decreased ventilation. Does that help? So then you can just automatically know it's always going to be, it's directly related to that V, okay? So if an increased ventilation, VQ ratio, you can just assume that's increased ventilation, that's going to be dead space, okay? Decreased VQ ratio, decreased ventilation, that's gonna be shunt, okay? I have more perfusion than ventilation then. Okay? Okay. I know this is a lot, so. So, decreased VQ ratio, what's gonna happen to ventilation? Decrease. Decrease. And what happens to our perfusion? I mean, it's pretty much the same, but we say increase. But yeah, and you're gonna have that increase in perfusion versus ventilation when you're looking at the two. So, this is gonna be our obstructive disorders, and that's gonna be really that dead space effect that we've talked about. But if it's a full-blown true dead space, or I'm sorry, shunt, it's going to be pneumonia, sometimes that pulmonary fibrosis, because it's a fibrotic at that AC membrane, right where that capillary is, okay? Hypoventilation can also cause that. Atelectasis, remember? Pulmonary edema or other ones. Yes?
With the line chart, so are these numbers kind of just representing the ventilation then?
Yeah, pretty, well, I mean, it just depends, because you can also have a change in cardiac output, which will change things. Does that make sense? Yeah. Okay, so this is called shunt. This is our shunt, right? So this is where we're talking about our shunt. So that's everything that's less than 1, okay? Because ultimately we do run, that 0.8 is a shunt. We have a slight shunt, okay? Okay.
We'll go in those spaces then. I wrote some notes down. I must have missed that.
Oh, I'm so sorry. Decreased and increased. This is what happens to ventilation. Decreased ventilation, so hypoventilation can cause this. And then versus our ventilation, we have an increase in amount of perfusion. Okay. So what VQ abnormality is demonstrated here? So we have a healthy alveoli on one. Over here we have some kind of damage. So looking at that, what's missing over here? What's going on? The capillary in the walls. So what is that? What disease process is this? It's dead space, but it's emphysema. Yeah, emphysema. So it's going to be dead space. Is it true dead space or is it dead space effect?
Dead space effect.
Yes, dead space effect. It's not a true dead space, okay? So this is emphysema, aka dead space effect. Look, you guys know it already. Woo! All right. What VQ abnormality is demonstrated here? We have a normal on the left and we have some consolidation, some bronchitis on the right. Is ventilation going to be impeded or is perfusion going to be impeded? Ventilation. So if I have a decrease in ventilation, an increase in perfusion? Shunt. Yes, shunt. And so this can go either way. So depends, I mean, you can just say shunt effect because it really, true shunt, I'm sorry. Because I feel like they're so wishy-washy there. It just really depends, okay? But I don't think I ever say bronchitis in any of the exams. Okay. What VQ abnormality is demonstrated here? We have a pulmonary embolism. That's a saddle. That's not good. Dead space. Is it true or effect? True dead space. Yeah, our PE is our true dead space. Especially that one. Okay. So this is that fun little line that we have here. So ventilation to perfusion relationships. Remember, on either side we have the true, whether it be shunt or dead space. Okay. So over here, you can see that we have our poor little sad alveoli that has shriveled up. It's not getting perfused, it's not getting ventilated, but we have a beautiful capillary that has perfusion. So it's been shunted over to this healthy alveoli. That's where we get that name from, right? Because it's shunting that blood flow. So remember, that's kind of what happens when we have that hypoxic vasoconstriction. It starts to shunt that blood flow to those healthy alveoli, okay? So, when you're looking at ideal, again, it's 1, normal's 0.8. If we have a low VQ, it's our shunt effect, and our true shunt is 0. So you can see blood flow is increasing. As you go this way, our ventilation is increasing, okay? So on this side, we have our true dead space, which is infinity or the 00. And this is where we have, this one right here is actually just vasoconstriction of some sort, okay? So our perfusion is lacking, but our ventilation is fine, right? So we have plenty of ventilation and a decrease in perfusion, okay? So this would be our high VQ over here. So everything greater than 1 is dead space effect until we get to our end of true dead space. Okay, what are some examples of dead space effect? Okay, emphysema. Emphysema has what? 2 B words. And blebs and boli. Those are our dead space effect, okay? Blebs and boli. Okay, so we're gonna fill out this fun little chart here.
Could you explain blebs and boli a little bit?
Yeah, so blebs and boli are just those really, all that the alveolar walls have pretty much been destroyed, and now you have a very weakened alveolar wall that is almost bulging, okay, because it's overventilated, and so it can rupture very easily. So those are the blebs, and the boli are usually the ones that are have I feel like more than just one alveoli that are actually bulging. Does that make sense? Okay, but they're about to rupture. So do you guys kind of remember those a little bit from, I know it's been a while, so. Okay, so when we look at our numerical value, that's going to be our greater than 1, less than 1, our infinity, and our 0, okay? Definition, I'm looking for, ventilation without perfusion, ventilation in excess of perfusion, whatever, okay? And then we can give examples as far as disease process, okay? So I want you guys to fill this out, and then we can go through it together, okay? So I want you to kind of think about it and do the numerical. You can use your little line, okay? And then at least do the definitions and the numerical value, and then we can go through and do the examples together if you want. All right, so I'll just give you about 5 minutes, and if you don't have it finished, that's totally fine. How you guys doing? Pretty good? I'll give you another minute and then we can go through it together. Okay, so the numerical value for this first one, so it says true shunt, so an absolute shunt. What is the numerical value for that?
0.
0. What is the definition? Who wants to answer that?
0.
Go ahead, Courtney.
Without ventilation.
Say it again.
Perfusion without ventilation.
Perfusion without ventilation would be the definition. So what's an example of a true shunt? Who wants to answer that one? Pneumonia, yeah, absolutely. What else? Go ahead.
Atelectasis.
Atelectasis. Looking for one more at least.
Edema.
Pulmonary edema, yeah. So atelectasis, pneumonia, pulmonary edema. Those are just a few of the many things. Okay. So shunt effect or relative shunt is another way you can term that. What is our numerical value? Who wants to answer that one?
Is it less than 1?
Yeah, less than 1, right? Okay, so then what is the definition of this one? Go ahead, Courtney.
Perfusion in excess of ventilation.
Perfusion in excess of ventilation. So we have what, more perfusion or less perfusion? More perfusion than ventilation. Okay. And what are some examples of shunt effect? Bronchospasms. Asthma. Absolutely. Yes. Typically our COPD patients are right around that shunt effect area, okay? All right. Next one is dead space effect. What is our numerical value? What's that? Yeah, greater than 1, okay? And that would be relative dead space as well. If you at first see relative, that means the same thing. Definition. What's the definition of dead space effect? Ventilation in excess of perfusion. So we have more ventilation than we do perfusion, okay? And what are some examples of our dead space effect? Blebs?
Emphysema.
Emphysema? Boli, yes, blebs, boli, and emphysema,
I'm
yes.
sorry, do the blebs and boli go with the emphysema?
They do,
Okay.
yes. Well, they're all, you can put them as 3 different things, or you can put blebs and boli together, but we do separate them out. Because not all of our emphysema, you can have emphysema without blebs and boli and still have the same issue.
If you have blebs, you have to have boli? Or vice versa?
Not necessarily, but you typically will eventually.
Okay.
Okay. True dead space. What is our numerical value? Infinity. What's the definition?
0 perfusion.
Yeah, ventilation without perfusion, right? And the example of that one is? Not edema, embolism, pulmonary embolism. Very good. Okay. Dead space effect also, I forgot to say, we have more ventilation than perfusion up here in our apex, right? So if I say like the conducting airways, remember, those are technically dead space effect, okay? Say it again.
The conducting area.
Yes, an apex of the lung. Because remember, we have perfusion up there, but the blood flow, because of gravity, is usually at the bases of our lungs, right? So we have some perfusion up there, and we have some gas exchange taking place, but not a whole lot, okay? Okay. So next I have physiological dead space, okay? So this is something that just is, did I say just, yeah, physiological dead space. This is something that is happening just because that's how our bodies are. So that I kind of just said a little bit there. So anatomically, an example of normal, I just have abnormal. Okay, so abnormal anatomically.
Did we do shunting?
There's another slide before this.
Yeah.
Oh, there is? I'm sorry, I thought I was, okay, I keep skipping them. Okay, so shunt, physiological shunt. So we're gonna do anatomically, capillary, and then the VQ mismatch of shunt effect. So what's an example of an anatomical shunt? You guys probably don't really know this yet because I haven't really told you too much, but you can have like a septal defect. As far as our infants, there is a, if you have a hole in the septum, it's called a PFA. So you have foramen ovale, pulmonary foramen ovale, is that what I'm saying? Patent foramen ovale, I'm so sorry. So you all are born, in utero, you have a hole in your heart between the septum. So your atrium and your atrium together, left and right, have a hole in them. So you have shunting of oxygenated and unoxygenated blood, okay? And that's okay for while you're in utero, but as a baby, an infant, when you're born, it starts to close very quickly, okay? So it should close within, a day or two. And if it doesn't, or if we don't want it to, then we will have to try to persistently keep it open. So if there is a defect and you're born with it and there's a hole in that septum and it hadn't closed in utero, then you will have an anatomic true shunt, okay? So you can put a PFA, so an anatomical shunt is when blood flows from the right heart to the left heart without being in contact with alveoli for gas exchange. Does that make sense? So it's going from the right side of the heart to the left side of the heart without going through the lungs. And that's what that septal defect is. There's a hole. So the right side of the atrium, when it's contracting, it's pushing the blood over to the left atrium and it's going down to the ventricle and out to the body without actually going through any gas exchange. So that's our unoxygenated blood mixing with our oxygenated blood. So that's what we consider to be an anatomical shunt. So that's why the PFA is considered that anatomical shunt.
What is that? Sorry, what does that stand for again?
Patent foramen ovale. Don't worry about it. You can just call it PFA. You guys don't really talk about it until your last semester.
So you said going from the right side of the heart to the left side of the heart without gas exchange?
Yes.
Okay.
Yes. So when you think about when you're talking about how you go through the heart and all of that, how the blood flows through the heart, it's skipping that step where it goes to the right ventricle, through the pulmonary trunk, out to the lungs, and then back through. It's already just going straight from the right atrium to the left atrium, okay? All right. So what would be a capillary, meaning down in the alveoli area? What would be considered a capillary shunt? So we've already talked about those, okay? So that's going to be down in the alveoli area, okay? So pneumonia, atelectasis, all of those are down, and that's considered to be an intrapulmonary or capillary shunt.
So pneumonia?
Yep, pneumonia, atelectasis, pulmonary edema, all of those, okay? That's going right here. So this is anatomical, okay? Meaning that, again, that blood flow isn't going through the process it should. It's right there at the atrium. It's not going through gas exchange in the lung, okay? This one is just saying there's some kind of shunt in the alveoli, okay? So it's at the capillary level. That's all it's saying. So intrapulmonary, inside the lung. Okay, does that make sense? So that's what we've been already talking about, intrapulmonary shunts, okay? So now, the VQ mismatch of the shunt effect. So just shunt effect, what is shunt effect? What are some things that cause shunt effect? Asthma, bronchospasms, that's all this is asking for or saying, okay? Shunt effect.
Oh, so the atelectasis and stuff goes into that capillary box.
Yep, that was this one right here, okay? Okay, physiological dead space. Same type of stuff here. So anatomical, what did we already kind of talk about anatomically? Where we have some dead space.
Like a clot in your capillaries?
So that'll be at the alveolar level, but I like where your head's at.
The apex of the lung?
Apex of the lung. Okay, so those conducting airways, that's our anatomical dead space. Okay? We're not talking about perfusion. So I know you're like, wait a minute, that has nothing to do with the heart, blah, 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 blah. That was perfusion, okay? So this is ventilation that's not going through gas exchange. Okay, it's wasted ventilation. And that's anatomically. So it's up in the apex, upper airway, all of that is considered to be wasted ventilation because it's not going through gas exchange, right? Okay, so the next one, alveolar. What happens at the alveolar level? We've already been talking about it, we'll say a true dead space. Whitney? Yeah, the pulmonary embolism, a PE. A PE. And then last but not least, VQ mismatch of the dead space effect. So what's dead space effect? Blebs, bullae, emphysema. Yeah. I'm gonna drill it. We're gonna drill it into your brains.
The one above from the shunt, the VQ mismatch of the shunt effect.
Yeah.
What did we put there?
So that was like asthma, bronchospasms, COPD patients in general. Okay, is it starting to click a little bit? Maybe a little, okay. Okay, so remember, we do have gravity that plays a big role in our blood flow. So the bulk of that blood flow is going to the bases versus our apex, okay? So that means that we are going to have, again, in the apex, we're gonna have dead space effect already happening, which is the anatomical, and I think that's just what this is going through. So alveoli are at the bases of the lungs. Do you think we would have increased VQ ratio or a decreased VQ ratio? And remember, if I say increased VQ ratio, I mean is there a bulk of ventilation or is there a bulk of perfusion at the bases of the lungs?
Decrease.
Decrease in ventilation?
Yes, so it's gonna be a decreased VQ ratio, and that's just normal. We have more perfusion because of gravity, right? So gravity is gonna draw that blood down to our bases, okay? So we're gonna have a lot of perfusion down there. We're gonna have some ventilation, but we're gonna have more perfusion than ventilation ultimately, okay? I mean, it's fine, it's normal, but just because of gravity. So we will have a decreased VQ ratio in the bases, because remember, decreased ventilation means that we're gonna have more perfusion. Okay? Have I lost you yet? Okay, I know. So then, at the apex of the lung, remember, we have more ventilation than perfusion, right? And that's just, again, because of gravity. So gravity's moving that blood flow to the bases, so we're gonna have more ventilation up here than we do perfusion. So we're gonna have an increased VQ ratio in the apex ultimately, okay? And that's just because of gravity. Okay. Any questions about that? Perfect. Okay. So, a reminder for patients with unilateral lung disease. What does unilateral mean? Uni means one-sided lung disease, okay? So the blank lung is usually positioned down. So if you look at this patient, they have a lot of consolidation over here. We don't know what it is. It could be pneumonia. But what side of the lung, when you think about our shunt effect and gravity and all of those things, which lung do we want to have down to help with gas exchange? The good lung or the bad lung? The good lung. We want the good lung down, right? Because that's where we're gonna have good ventilation, good perfusion. So hopefully we can help this patient get some oxygen, because this side, there is gonna be very poor ventilation. We're gonna have a huge VQ mismatch over here, right? Poor ventilation and perfusion, okay? So that blank there says, it should say good. So when we talk about, and I give you examples of someone, and if someone has left-sided, or usually, remember, it's always usually the right, but pneumonia, whichever side it's on, we want the other lung down if we're gonna position a patient, because that's the lung that's gonna get perfused and ventilated a lot more than the other, okay? So, MBRC, that's our national board, who we actually have to get licensed through. We have to pass our COARC exams, or our MBRC exams. So position the patient to minimize hypoxemia. So we're gonna reposition them. So you'll even find, like I've had in the ICUs where they've positioned their patient, they've turned them, and then they instantly tank. And it's because now we have the bad lung down, and then we have to actually turn them back to the other side. So it's a thing. It just depends on the severity of the lung disease. So okay. So have you guys talked about alveolar ventilation, minute ventilation, things like that? Okay. So we do have some equations that we're going to go through. I know that it's not your favorite thing, but these should be hopefully somewhat make sense when you break them down. Okay. So let's go through them together. Minute ventilation. And this is all because we're looking at dead space and alveolar ventilation to understand how much of that ventilation is actually getting down to the alveoli, okay? So when we're looking at that, we're going to, like some of these are gonna be used in that equation. Remember, we had our respiratory ventilation per minute over our cardiac output. So some of these are gonna tell us how much of that alveoli is actually getting ventilated, depending on a patient's respiratory rate, tidal volume, dead space, all those fun things. So this is how we're gonna find that stuff out, okay? Because you really, this is the only way you're gonna be able to do it without having any kind of, box or machine. So minute ventilation, which it can be also written as MV or VE. That's like on our ventilators, right? Why? I don't know, okay? Okay, so VT times respiratory rate. So VT stands for tidal volume. We're just doing the ladybug, right? We know how to do this one. This one's not hard. So this is an example. What's our normal? 5 to 7 liters per minute, okay? We know how to do that one. Same thing goes for our tidal volume, right? So you guys are haven't really probably talked too much about ideal body weight, have you? There is an equation for that as well, but we'll get that a little bit later. So ideal body weight is really going to have an impact on what our tidal volume should be, okay? So is it the taller or the wider the patient, the bigger the tidal volume? Do you know? Is it the taller or the wider?
For the
Wider.
The wider? The wider? It's the taller. So you can weigh 400 pounds, but your lungs have not gotten any bigger than what they had when you were 150, okay? So dependent on your body weight a little bit, but really your height, okay? Your height, and if you are a female or a male, okay? So the taller you are, typically the larger your lung capacity is, okay? And of course, males are always a little bit larger than females, okay? So when we take our, when we do ideal body weight, you're actually just taking height in inches and you're multiplying it by the factors, and that's all it is, and adding 5 at the end, or 6 for males. So, but we'll worry about that at a different time, but we don't even take the weight. That's not even a factor when we do our ideal body weight for that patient, because weight doesn't really have a huge impact. There are some things that weight does come into play, but not necessarily when we want to find an ideal, okay? So remember, tidal volume is just going to be our ladybug again. So we're taking our minute ventilation over our respiratory rate, right? Does everybody remember that? MV divided by respiratory rate, VT. Okay. All right. I want to make sure I'm on the right. Okay, so what we usually do is we say we can give an approximate dead space. So if we don't have the actual dead space, we can use an approximate, and all we say is the approximate dead space is 1 mil per pound. Should be ideal body weight, okay? So dead space ventilation per minute. So if I have a patient that weighs 150 pounds, what is my estimated or approximate dead space if it's 1 mil per pound? 150. Pretty easy, right? If you have someone that's 180, it's gonna be 180, okay? So this is how you can use your approximate dead space in this way. So you just take 1 mil per pound, okay? So that would be our VD, our dead space. VD stands for dead space ventilation, okay? So approximately 150 mils of that patient's breath is going to be lost as wasted ventilation is what that's saying. So our dead space ventilation, that approximate 150 mils of their overall tidal volume. So if it's 400, right, we take away 150 of that, okay? And what's left is what's gonna get to the alveoli. The other are wasted in our conducting airways. So that's what that approximate is getting us, okay? So if we're trying to find out how much is wasted in a minute, what do I need to multiply that by? Your respiratory rate, because that's your breaths per minute, right? So if I know that my patient has a VD or a dead space ventilation of 150 mils and I'm breathing 10 breaths a minute, I know that in a minute, this patient is having a 1.5 liters per minute or 1,500 mils of wasted dead space in a minute, okay? So I know you're like, why do I care about that? We care about it a little bit because if it's increased dead space, if we have an increase in dead space or ventilation, it's gonna change a little bit, right? So we have to understand that. Yes?
The dead space ventilation, would we get that from like a machine or something, or how
Like to
would
get
we
the actual dead space, yes, you have to get a machine
Okay.
to actually get that. Yeah. So this is just kind of our approximate.
So that would always be given though, like
Yes.
it's on the test.
So I'll say like you have a 150 pound female, and then that would be your approximate alveolar. I'm not gonna necessarily call it out. Does that make sense?
Yeah.
Okay, I know, right? That'd be too easy. Okay, so this is to identify the wasted ventilation per minute, okay? So if I ask you to do dead space ventilation per minute, you're gonna multiply it by your respiratory rate, okay? If I'm just telling you to get a patient's dead space, it'd have been the 150 mils, okay? Per breath, that would have been per breath, right? And then per minute is when we multiply it by the respiratory rate, because that's the rate per minute, right? Breaths per minute, okay? So we're gonna use this same type of formula, and we're gonna do it to alveolar minute ventilation, okay? So how do you think I can find out how much is getting to the alveoli?
You just made my brain fart.
Well, I know what's not making it. So do you think whatever's left over from that tidal volume is gonna be going down to the alveoli probably? Yeah. So if I know what the approximate dead space ventilation is, I can find out what my per breath alveolar minute ventilation is. Okay, I see a lot of faces. Okay, so we'll get to that.
We're gonna do like examples.
Yes, I have examples on your worksheet. There's some examples too, so don't stress about it, but yes. Okay. Before we get to alveolar, we have our VDS-VT ratio. So this is going to be the ratio of our physiological dead space versus our tidal volume. So we know what VD is, right? That's our dead space ventilation, so that was our 150, right? And we're gonna divide it by our tidal volume, okay? So the way we do this is actually our PaCO2, which will be given to you. How do I get that number? PaCO2. Close. ABG? Yeah, PaCO2. I can only get that if I have an ABG. Okay, so that will always be given to you. You're not calculating it, it'll be given to you. PeCO2. I don't know, have you guys seen this yet? Exhaled CO2. So a lot of the facilities you go to will have exhaled CO2 manometers, okay? I don't know if that's, I'm co-oximeter, sorry, I lost the word. Co-oximeter. So it's going to be measuring how much of that CO2 the patient's exhaling, okay? So typically we can take and look at our PaCO2 and say, how close is that to our PeCO2, and say, oh wow, they're pretty close. They should be pretty close. They might be off by like 3 or 4, but they should be pretty close. If not, then there's something going on, okay? So I'll also give that to you. You're not gonna be calculating that. So you'll be given all of these. So you're taking what your patient's getting in the blood minus what they're exhaling, okay? Dividing it by what they're getting in the blood. And what is that telling us? That's really telling us how much of that ventilation is taking place within the lung, okay? Versus the tidal volume as far as pertaining to our CO2. So this is the ultimate dead space, okay? So this is going to tell us our real dead space ventilation based on the physiological dead space and our tidal volume together. I know, this is a lot. So this is our dead space equation. Okay, so this is if we didn't have the, we don't have the approximate, we can calculate it out using these numbers. Kaylee, you good? Everyone good? I know, this is stressful. More equations. Okay. So, if I have an increased VD-VT ratio, it's saying that I have an increased dead space in the lungs, okay? So if this number is increased, so greater than our normal, which is 30 to 40%, so if it's 50, 60, that means it's increased. That means we have increased amounts of dead space in the lungs. So that means we have emphysema, Leb's voli, something like that that's going on, PE, something like that is happening within the lung, okay? That's scary. That's not good. Okay. So if I have less than normal, so less than 30%, that's telling me that I might have a shunt actually happening, okay? It's the opposite. Yes?
Is that the thing with the tube mouthpiece on the front? They like breathe
Yes.
out, breathe in, and breathe. You saw me.
Wait, say it again.
Did she like breathe out? They like breathe out, breathe in, and breathe out again or something?
So that would be more of, breathe out, breathe in, like, they go, blow, 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 blow.
Yeah.
Okay, so that's fourth vital. So this one is going to be usually on our ventilated patients. So you guys probably haven't seen that yet. So it's usually like in line with our vents. So,
What about, like, on the end of an ET tube?
yes,
Is that what that?
yes.
Okay.
Yes, it has like a little yellow on it and it will go
Uh-huh,
back, yes.
uh-huh.
And it will be projected on the screen.
Okay.
Mhm.
Got it.
Yes. Okay. So this is gonna be a good indicator to tell us if we have dead space, increased dead space or shunting in the lung, okay? Because we're using a value that's coming from our arteries, and we're using a value that's coming out of our lung, okay? So it's gonna tell us and see the difference between the two and if we have an increased amount of dead space or shunting. That's huge. So these will be on your assessments when you're a sophomore. You'll be doing this on your patients, okay?
Wait, what? Tell me on what?
This equation on your patient assessments. Okay. I know this is a lot, so just take a breath. That was our dead space. Now we're gonna talk about alveolar ventilation, okay? And this one's going to be per minute. So again,
Or, didn't we skip the one before too?
we did?
I thought you did.
One more.
You meant to skip it.
That one.
Oh, I did, I'm so sorry. Okay, so this is just going to be per breath. So, if you wanted to just do each breath, you would know that you would take your 150 and divide it by your respiratory rate to get per breath, okay?
Is the 150 just an example of the body weight?
It is, it's an approximate,
Okay.
okay. What, you have a question?
No. No.
Oh, you don't, okay.
No, it just sounded like everybody was supposed to get up and leave.
Oh. You're like, we're out of here, we're done. Hey, I get it, this is a lot of equations. Okay, so alveolar ventilation, we still have to find our VD, okay? We still have to find our VD, we have to know our tidal volume, which those will be technically given to you, okay? So you would just use your approximate. So if you take your tidal volume and you subtract it from your 150, okay, we'll just say it's 150. You get that number and then you multiply it by the respiratory rate. So don't put all of this into your calculator, okay? So you do the ones, remember you have to use the numerical math or whatever. Everything in the parentheses goes first, and then you take it and you multiply it by your respiratory rate. And that's going to tell us how much of that ventilation is actually getting down to the alveoli, okay? And that's per minute because we're multiplying it by the respiratory rate. Okay? All right. And then this would just be per breath. Again, it's the same as the VD. We're just using the alveolar ventilation that we had gotten before. So that alveolar ventilation would just be the VT minus the VD. Okay? Not times respiratory rate, because that's per minute. We're just trying to do per breath. So you get the difference between the two, and then you divide it by the respiratory rate, just like you did with the dead space, okay? Okay. So let's go ahead and practice, okay? So first, let's get our tidal volume. Okay. You guys know how to do that one, so go ahead and get your tidal volume. So you have a patient that weighs 180 pounds, has a respiratory rate of 25, and a minute volume of 5 liters per minute. So we're gonna estimate the following. So tidal volume, we're using our ladybug, right? MV over respiratory rate and tidal volume. So to get my tidal volume, I'm gonna need my minute ventilation and respiratory rate, right? Well, guess what, you got both. So go ahead and do that equation and tell me what you get. 0.2, so what is that?
That would be
Smaller.
Move your decimal.
2, so that'd be higher. So that's what it's,
So we're not doing that yet.
oh.
No, so we're just getting a tidal volume, right? So what's a normal tidal volume?
5 to 7.
Yeah, 5 to 7 mils per kilogram, right? Okay, so
25 divided by the 5.
sorry, so it'd be the minute ventilation, so 5 divided by the 25, and you got 0.2. So then you gotta move the decimal, right? 1, 2, 3, so it's 200 mils?
Yeah.
Okay, that's a very little tidal volume. Why do you think that's happening? Is it because of the respiratory rate, maybe? That's on the lower end of our minute volume, okay? So, 200, that is the tidal volume. So let's do dead space volume. So remember, what is our dead space? So we go back. Our approximate dead space ventilation. What do we use?
Dead space divided by respiratory rate.
You talking about the 1 mil per pound?
Yeah, yeah, no, I know, I was like, that was dead space volume. So that's gonna be what?
180.
180, okay? So tidal volume was 200. That's just 180, okay? 180 mils. So this is our dead space volume, okay? Or ventilation, okay?
Hold on. Where y'all get the two from?
The 200 we did,
5 divided by 25.
Oh, 5 divided by 25.
Yeah,
I was doing 25 divided
volume
by 5. Okay.
divided.
Yes.
Put 'em in one spot.
Okay. All right, so next we're gonna do the dead space minute volume, so per minute. So we need our VD, right? And what are we gonna do with that? We need it a minute. What do we always do to get it in a minute?
Respiratory rate.
Multiply it by respiratory rate, okay. So by VD times respiratory rate. So what is our VD? We know it's the 180, and we're gonna multiply it by 25. What is our dead space per minute?
4,500.
So 4.5 liters per minute. Okay. So let's do alveolar minute volume and alveolar minute, alveolar volume and then alveolar minute volume. Okay, so how do I find out how much is getting down to our alveoli? So remember, we're gonna go back, alveolar ventilation. How did we find that out? How many mils, the volume? So I take my tidal volume, right? And I subtract it from my dead space. That's how much is getting down to our alveoli, right? Because the dead space isn't, that's wasted ventilation. Does that make sense? No? So take your 200 and you minus your 80, right? Your 180. What'd you say, 20?
Yeah.
So 20 mils, so not much is getting down there. That's bad. Okay, we have a very low tidal volume and a fast rate. That's actually E, I'm sorry. And then I think I have these flip-flopped. So that's E, and then to do it per minute, what do we do?
Times the respiratory rate.
Yeah, we just multiply by the respiratory rate, just like we did with the dead space. So 20 times 25 is what?
400.
400? Is that what you guys got? 500? I'm gonna say I have 500, but, okay. So, what is our alveolar minute volume, minute ventilation? It's going, which is D, okay. It is 500 mils per minute. So, not a lot, not very good. Sorry, I did E and then I did D. Those should really be, because you have to get E to get D, so I just need to flip-flop them. Okay. I know. Does everybody understand a little bit of those? It's gonna take some time.
I'm gonna need some practice.
Yes.
You do it kind of fast, so.
I know, well,
Go back, look at the slides. and the steps.
yes, okay. Good morning. Okay, so why is ventilatory pattern important? So just looking at that, we can tell, right? So we had a fast rate and a shallow tidal volume. So how much is reaching our alveoli? 20 mils? Like, that's awful. That's not a lot, okay? And per minute, only 500 mils. That's like a normal tidal volume. So you can see why these patients that have a rapid shallow breathing are hypoxemic, right? Because this is what's happening, okay? It's not reaching the alveoli, so there's no gas exchange taking place, okay? So, a patient weighing 150 pounds changes her ventilatory pattern throughout the day as she develops increasing dyspnea, but continues to have the same exact minute volume. Estimate the alveolar minute volume for each. So remember, alveolar minute volume, so we have to get our VA, and we multiply it by our respiratory rate, okay? So how do we get our VA? Do you remember? Tidal volume minus dead space, okay? So to get my VA, I have to have my tidal volume and I minus it, my dead space to get my VA, okay? big A. So, we don't have a tidal volume, but we have all of the things to get, oh no, we do have a tidal volume, I apologize. So we have our tidal volume, and we have our VD, which would be what? What would be our dead space, our approximate dead space?
150.
150. Okay, so each one of these, you're going to take your tidal volume, subtract the 150, and multiply it by the respiratory rate, which is right here. Okay, so go ahead and do that, and then we'll go through the answers and see what you guys got. So first step, right, is to find your dead space volume, which is the 150. Okay, who wants to answer number one? What'd you get? 4.2, yeah, so 4.2 liters, okay? So is that tidal volume big, small, normal?
Small.
That tidal volume small to you?
Oh, I'm sorry. Big.
Sorry, this right here,
Oh,
1,000
okay.
milliliters. That's a liter. It's a whole liter. That's a big tidal volume, okay? Now our respiratory rate is quite slow, right? That's a pretty slow rate, but we have a huge tidal volume, okay? But that came out to be 4.2 liters. Okay, so then we're gonna increase our respiratory rate, right, to 5, and then our tidal volumes drop down to 500. So that's the difference here. Go ahead. Did you have a Cammie, you said? Oh, I thought you were raising your
no.
hand. Who wants to, she said no. Who wants to do this one? Anybody else? Sean, you wanna do it? Go ahead.
Is it 3.5?
3.5 liters, okay? So did our overall VA increase or decrease? It decreased, so our, what's getting down to the alveoli has decreased. But we increased our rate. I mean, we did decrease our tidal volume though, right? Okay. So our next one, we increased our respiratory rate to 20, and we decreased our tidal volume to 250, which is quite small, right? Okay, who wants to give me the answer to this one, Brianna?
2.
What'd you say, 2? 2 liters per minute. So we are now even less. I mean, we kind of thought that, right? That one's kind of self-explanatory looking at that. So what do we see from here? Does our tidal volume make a big difference? Yeah, ventilation pieces in general. So if we have, our respiratory rate and our tidal volume together make a huge impact on how well we're gonna have gas exchange, right? Okay. So how does the ventilatory pattern affect alveolar ventilation?
It affects how much gas exchange is taking place?
Yeah, so a ventilatory pattern is going to affect how much volume gets to the alveoli, out to the alveoli level. You guys, I'm sorry, losing my mind. So, what is the most effective pattern for alveolar ventilation? So let's go back. Which one had the highest alveolar ventilation?
The first one
The first one.
has the lowest respiratory rate.
So we're breathing slow then, right?
Mhm.
And is this shallow or deep?
Deep.
Slow and deep?
Mhm.
I think so. So slow, deep breaths are usually the best for alveolar ventilation.
What was the first blank?
How does ventilatory pattern affect alveolar ventilation? So if our ventilatory pattern increases, like our rate increases and our tidal volume decreases, we're gonna have less ventilation reach the alveoli, right?
Mhm.
But if we have a deep breath and a slower rate, it's going to increase the amount of ventilation that gets to the alveoli. Okay,
So repeat that one again, number one.
okay. So ultimately, how is the pattern affecting it? So if you have an increased respiratory rate, you're breathing rapid, right?
Mhm.
So, and if you have a decreased tidal volume, you're breathing shallow. So a rapid shallow pattern, what is it gonna do to our, and that was the last one. So a rapid shallow pattern, what is that going to do to our alveolar minute ventilation? Decreases it. So our VA, I'll just shorten it to VA, the alveolar ventilation, because it's not allowing for that because the tidal volume is so little, I guess, it's not gonna make it down to the alveoli. Also, you're already taking your next breath in, right? So if you're breathing rapid and shallow, it's just not enough volume to get down to the alveoli, and it's not enough time either, okay? So both of those together are really going to decrease that, ultimately, how much is getting down there. So if we breathe slow and we take a deep breath, that's gonna increase our alveolar ventilation, or the volume that gets down there. Does that make sense? So that's how our pattern ultimately changes or affects our alveolar ventilation. Okay. So, effect of ventilation pattern on our alveolar ventilation, or volume. The important conclusion from this is that an increased depth of breathing, so the first blank is increased, is far more effective than an equivalent increase in respiratory rate. Is the next blank. Okay, so if you take a deep breath in, you could even, if you look at it and did the math, if you had a higher rate but were taking bigger breaths or higher tidal volume, you would actually end up having a decent amount of that alveolar ventilation because of that deeper breath. So it does make a bigger difference as far as tidal volume goes. So, or oppositely, a decrease is the first blank in depth of breathing.
You said, I'm sorry, what was that one you just said? Decrease.
The first one right here
The second one you just said, decrease.
at the top.
No, right here.
Okay, so it would be, that's a decrease.
Okay.
Decreased depth. It leads to a significant and perhaps a critical reduction of alveolar ventilation. And this is because the anatomic dead space volume represents a fixed volume, and the fixed volume will make up a larger portion of a decreasing tidal volume, so larger.
And the two first blanks, were they both increased?
They were. Okay. So next, we're gonna do some more practice. So calculate the exhaled minute ventilation for a patient who has a tidal volume of 800 and a respiratory rate of 8. So all we're doing here
Is this a lady one?
we're doing the ladybug. It's a minute ventilation. So, remember, MV, respiratory rate, tidal volume. All right, what did you guys get? Yeah, so 6.4. All right. Estimate the, number 2, sorry. Estimate the anatomic dead space for the above patient who is 6 feet tall and weighs 180 pounds. What is our estimated or approximate dead space?
180.
Yeah, 180, right? So now that we have our approximate dead space, right? Let's estimate the alveolar minute ventilation using the data from the above. So what do I need? I'm getting alveolar minute ventilation. So I'm trying to find out what's getting to the alveoli. So what do I need? Tidal volume,
And dead space.
dead space, and respiratory rate, okay? So what's my tidal volume? 800. And what was my approximate dead space?
180.
180, which I got from just the weight. What is that? 800 minus 180. What'd you say?
620.
620. And now I take that 620 and I multiply it by my 8. And what did you get?
4,960, which is 4.9.
4.9 liters per minute is what our alveolar minute ventilation is. Yes.
When we get answers like that, do you want us to round up or would you like us to just leave it?
You can do either. So if it's a multiple choice and I had this and there was 5 listed, go ahead and choose 5, okay? Yeah, I mean, it's usually I will, if it's a multiple choice, even on your boards, they'll have it to where it will be, you know, more of a whole number than an actual approximate, like there are the actual exact. Good question. Okay, any questions about this? You getting it? Feeling a little bit better? Okay, good, because we have more practice. Okay, which of the following ventilator settings would provide the optimal alveolar ventilation? So, how are we gonna figure that out? We really don't have any dead space. So, do you remember what was the best pattern?
Slow, deep.
Slow and deep, okay? So, what is our largest tidal volume? 600. And it's also the lowest rate we have. So do you think that would probably be the most optimal? Yes, okay. Does that make sense? Slow and deep. Okay. So now we're gonna talk a little bit about hyperventilation and hypoventilation. So we should probably be pretty familiar with these terms. Hyperventilation, hyper means what? Increased or high, right? And hypo means decreased or below, okay? And we're talking about ventilation. So hyperventilation, increased respiratory rate and or depth is what causes or what you see with hyperventilation. And how do you actually know a patient's hyperventilating? Because they can be breathing fast but still have a normal PaCO2. But you have to have a decreased PaCO2 to be technically hyperventilating, okay? So we would have to get our blood gas to get that, okay? So a decreased PaCO2, because why? Why a decreased PaCO2? Who can tell me after what we've been talking about? Hyperventilation, so we have a increased rate and depth. Yeah, there's less of that volume getting down to the alveoli, right? That's what we just talked about. So so is gas exchange taking place? No, okay. So are we gonna we're not giving oxygen, and we're also not exhaling and taking out that CO2. So now the CO2 is staying in the blood. So when I do a blood gas, it's gonna be elevated. What's gonna probably happen to my oxygen? It's gonna drop. So our patient's gonna be hypoxemic as well, okay? All right. So then hypoventilation, we have a decreased respiratory rate and or depth to a fault. This is not good in this case, okay? Because we're not having a deep breath, right? We're probably having a slow rate and shallow, okay? We're not getting that good deep breath, okay? So how do you say a patient's hypoventilating? You have to show some evidence, so increased PA CO2, okay? So now we are, again, not going through any of that gas exchange, okay? So now our increased PA CO2, because again, we're not having that gas exchange, it's also staying in the blood, okay? So it's going to increase our CO2, and then also we are going to have a decrease in our PaO2, okay? All right, respiration, external and internal. There are two kinds of respiration. You know this. External is where it's between the blood and air. So that means our alveoli, right? It's coming from the atmosphere into our alveoli. And now in that capillary, it's going to go through gas exchange, okay? So it's in the lungs, typically, right? Internal is gas exchange between blood and tissue, okay? So now we're talking about, we're down into the systemic area. We have our organs, we're providing blood to, and it's that gas exchange at that level, okay? So, how does ventilation differ from respiration? Does anybody know?
Ventilation is just the movement of air.
Yes, ventilation is moving air in and out, right? Respiration is actually
The CO2 and
the gas exchange, the CO2 and the oxygen, get the CO2, exchange of CO2 and oxygen, absolutely. So, ventilation is just the mechanical movement of air in and out of the lungs. Respiration is the exchange of oxygen and CO2. Okay. So if we have a hypoxic patient, we tend to have what we call hypoxic vasoconstriction, right? So what happens is whatever area is not ventilated, we have that shunt of blood over to our better perfused alveoli, okay? So we probably have some type of a shunt going on over here. So it's going to shunt that blood over to a better perfused open alveoli, okay? So that is called hypoxic vasoconstriction. So the definition, so we don't have to open our pages, is the redistribution or the moving of pulmonary blood flow to areas of the lung that are better perfused. Redistribution of pulmonary blood flow to areas of the lung that are better perfused or have more perfusion. So these are examples of hypoxic vasoconstriction. So localized area of shunting, which we talked about. We also, this happens in utero, and that's normal. They shunt blood as far as our babies at high altitudes, right? We talked about some of that a little bit. And then any kind of diffused pulmonary disease, meaning throughout, okay? So those are some examples of when hypoxic vasoconstriction occurs, and we would shunt that blood to better ventilated alveoli, sorry. Okay, I know we're just kind of going through some things. Cor pulmonale, what is cor pulmonale? Right-sided heart failure. And do we know that it's usually a chronic lung disease patient that, or you see it, I guess, more in chronic lung diseased patients, so our COPD patients, right? Do you remember why?
It's more, wait, we won't say it again?
Say it again.
Oh, what would you have? Sorry.
It's okay. Why is cor pulmonale found in a lot of our chronic lung disease patients? What's happening in there?
Right-sided heart failure, right?
Because of the pumping, yeah, cause like
The vasoconstriction?
yeah.
That's okay, because the hypoxic vasoconstriction. So if you are chronically hypoxic, then you chronically have that vasoconstriction, okay? Now, if you have tiny vessels that are constricted in the lung, is it gonna be harder for the right side of that heart to pump that blood into those vessels? Yeah. So that right side of the heart is gonna be working an overload, okay? It's gonna be working very hard to get this little bit of blood flow through. So after a while, it starts to fail or fatigue, okay? So that's when we have that cor pulmonale take place, okay? Meaning, this is congestion, this is the road closed. So it's saying that some of those vessels are so constricted that it's causing that backflow of blood, but also really straining that right side of the heart. Because remember, that's what's pumping to the lungs, right? Is the right side. It goes from the right atrium, right ventricle, through the pulmonary, right? Pulmonary valve, to the lungs. And right there, that's where it's trying to pump through that vasculature. Okay, once it gets through, then it goes to the left side. But it's constantly trying to pump through. So what happens when you have right-sided heart failure? Everything starts to back up, right? Where is it gonna back up to? So remember, our inferior superior vena cava, right? Right there, it's gonna back up. And where does it go? It doesn't, because it's backing up. Forward is lungs. You're thinking of left-sided heart failure. Right-sided is gonna back up into the systemic, right, where we just came from. So it's gonna cause pedal edema. It's gonna go down to the legs. It's gonna back up into our liver, hepatomegaly. It's also gonna cause, does anybody know what this picture is? JVD? Jugular vein distension. So it's backing up, that's the vein that it backs up to go to up to your brain and your head and all of those areas. It's backing up into all these veins, and it doesn't know what to do, so it kind of causes a lot of this fluid or edema and swelling to occur. So that's why you find hepatomegaly is one of the number one signs of cor pulmonale, because the blood backs up into the liver's right here, okay? It backs right up into that, and then so on and so forth. So it gets down to the pedal edema, your feet, all of that. So signs and symptoms of cor pulmonale. I promise you're gonna wanna know these. I promise you. Okay, now we're gonna shift our head back to shunt effect, dead space, true shunt, true dead space. Okay, we'll get through a few of these. So point 8, what is that technically? It's normal, but it'd be on the shunt effect side, okay? So, B, shunt effect. Ventilation without perfusion. So we have low blood flow. Which one is that? True dead space. We have ventilation, but no perfusion.
What was the, sorry, what was the word for that?
Shunt effect.
All right. No, you're okay. Ventilation less than, or, yeah, so this is another way to say it. Ventilation less than perfusion. So it means perfusion is, there's more perfusion, but it's not without. So which one would it be?
Shunt effect.
Shunt effect. Because we have less ventilation than perfusion, but we still have ventilation, okay? So, that one was shunt effect. Ventilation in excess of perfusion, so more ventilation. Dead space effect, so C. See how these can be very confusing? Perfusion without ventilation.
True shunt.
True shunt. True shunt.
C.
C, yep, dead space effect. Okay, now we're getting into numerical values here. Okay, a VQ that equals 0.
True shunt.
True shunt. A, true shunt. A VQ less than 1. Shunt effect. Good job, you guys. B. A VQ ratio greater than 1. Dead space effect. VQ infinity. True dead space. Okay. Generations 0 to 16 through 19 of the tracheal bronchial tree. What do you think is going on there?
Is that true dead space?
It's not true dead space.
Effect, that's a
Dead space effect, right? Because we do have some perfusion. So C, dead space effect. So this is those conducting airways, upper airway. Okay, pneumonia. True shunt, yes. True shunt. Asthma. Shunt effect, yes. Shunt effect. B. Good job, you guys. Blebs and bulli. Dead space effect. Atelectasis. True shunt. Shunt. Because we remember we don't have ventilation. Pulmonary embolus. True dead space. Yes. The apex of the lung.
True shunt.
Nope.
Dead space effect.
Dead space effect, because remember, we have more ventilation than perfusion because of gravity. Gravity is bringing that, we have more blood flow at the bases and less at the apex. So we still have perfusion, but we have more ventilation, okay? So it's dead space effect. Okay. The base of the lung then is shunt effect, yeah. Refractory to, oh, did I skip one? An infant born with a ventricular septal defect and a right to left shunting. It's a true shunt, is that what you said? Yes, so this is that PFA, okay? Refractory to hypoxemia. So this one's hard. So this would be, if you're refractory to hypoxemia, typically it's from consolidation, okay? Because you're needing more pressure than oxygen. So remember, when we say someone's in refractory hypoxemia, positive pressure ventilation is what we want to give them.
So shunt, true shunt.
It's a true shunt. Have you guys not talked about that in Dr. Krager's class? Okay. So refractory to oxygen therapy is going to be a true shunt. Okay, overall, the normal VQ ratio is about 0.8, yeah, 0.8. In the healthy individual, in upright position, the VQ ratio is highest in the lower lung regions. Is that true or false?
False.
Correct, because a high VQ ratio means that you have what?
High ventilation.
High ventilation versus perfusion. So remember, let's break it down. We're in upright position, so we're sitting up, so blood flow again, gravity's taking place, it's doing its thing. The VQ ratio is highest, meaning greater than 1, right? And the lower lung regions. Okay, so what's going on in the lower lung regions?
Perfusion.
We have a shunt effect, right? So if you have a high VQ ratio, remember, that's meaning you have more ventilation than perfusion, and it's perfusion that's happening down here versus ventilation, okay? I know that was kind of a tricky one. So then we're gonna flip it. In a healthy individual in the upright position, the VQ ratio is lowest in the upper lung regions.
False.
False, because it would be the VQ ratio. Again, if it says it's a low VQ ratio, what is it talking about? Because remember, the
Low ventilation.
the ventilation and the increase-decrease sign are going to be directly related. So if I say it's a low VQ mismatch, it's gonna be, or low VQ ratio,
Low ventilation.
low decreased ventilation to perfusion.
So the first one was true?
No, they're both false.
Oh, okay.
They're
I thought
both
it
false.
was false. Okay. all
They're
right.
both false, okay? I know it. Okay, when alveolar ventilation is 7 liters per minute and the pulmonary blood flow is 9.5, the VQ ratio is about. So take 7 divided by 9.5. What do you get? 0.736. So parlay D, 0.7. I think we're running out of time. Last one, ventilation with no perfusion is the definition of
That's big.
dead space, and that'd be true dead space. All right, I'll let you guys finish the other ones out, and then we can go through them next week. So we did get through that. I did not expect that at all. Yes.